the choice of pelvic osteotomy in DDH, le choix des ostéotomies pelviennes dans la luxation congénitale de la hanche. This problem often discussed in case of residual acetabular dysplasia, of course after reduction of dislocation if there is. For this we invited our colleague from Saudi Arabia, Dr. Dalal Boubshid, to share this his experience and to discuss the indication of each osteotomy, type of osteotomy. Welcome.
Thank you. So, again, today I'm just telling you stories. So when I first started, again, when I came back from my fellowship, and I was very happy that I finished. So on one of my first clinics, I saw this patient. She was 4 years old. She had 1 year post bilateral DDH surgery. Is this acceptable? So she had bilateral hip dislocation. Of course, with the inlet view, she has fixed flexion deformity. So I got scared. This is one of the first, this is not something you start your career with as a consultant. So I had to go back to her initial x-rays. So when I saw her initial x-rays, she had bilateral Salter done at the same time. And you can see the K-wires are almost intra-articular. And her spica position was an internal rotation, which derotates the femur. So that's why even if you do a good capsulorrhaphy with the internal rotation, you can derotate and the hip can dislocate. So I was asking myself, why is Salter the gold standard? Dr. Azmi was asking, why is Salter still the gold standard? If we cannot do it bilaterally, because both of them hinges on the pubic ramus. So if you do a pelvic osteotomy one side and a pelvic osteotomy, a femoral Salter on both sides, you're just causing a fixed flexion deformity. You're not hinging. You're not holding the acetabulum in a corrected position. So that's what made me start to make this lecture. So I made this lecture initially, then I started to give it almost everywhere. So type of pelvic osteotomy, of course, from the residency, we know it. It's there in Salter, it's there in Campbell. It's there in Tajian, redirectional, complete, and incomplete, reshaping, and salvage. The complete are known. The most famous is the Salter, and the incomplete are the Dega, Pemberton, and San Diego, and they almost all look the same. The salvage, why we call it the salvage, because it covers the acetabulum with a fibrocartilage, not a hyaline cartilage, and that is suboptimal for the pelvis, but we do it in case of emergency. Now, how do we choose? It's there everywhere, right? You have like 17 types of pelvic osteotomy, but how can we choose them? How can we ask our resident when they are in the exam to choose the correct pelvic osteotomy? And how can we in the clinic choose the correct osteotomy for the patient? So after reading, I just made this summary. So I asked the resident everywhere to take a photo of the schedule. You want to distribute, you want to do whatever it is, but that helps a lot. And it helped me. So if you can see, the criteria are the age of the patient, where is the deficiency, and where do you need to cover, the degree that you need to correct. So the acetabular index minus 25, which is the desired acetabular index, is the degree of correction. Where is the hinge of correction, and what is the contraindication so that you can exclude that osteotomy altogether. So if you can see, if your child is 1 to almost 2 years, you only have these 3 options. You cannot talk about triple and shelf and GANs while the child is coming as a primary DDH. So that's the first criteria that would make you choose what type of osteotomy. The second criteria is where the deficiency is. We know that the common deficiency in DDH is the superior lateral part, which is usually covered by Salter osteotomy. Pemberton and Dega can cover anywhere, depending on where the deficiency is. And that's what changed the gold standard. So a Salter osteotomy, by the best of hands, will correct 10 to 12 degrees. It does not correct more than that. And I've shown you in my last lecture some of my patients with 60 or 70 degrees of acetabular index that you need to correct 30 degrees. So a Salter would not be ideal, although it can correct, but it will have some sort of a residual dysplasia. And then where the hinge is, as I told you, if you want to do a bilateral osteotomy at the same setting, a Salter is not a good idea because you are creating a fixed flexion deformity. But if you need to do bilateral and the hinge is central in each area on the triradiate cartilage, then you can do a Pemberton or a Dega osteotomy. And the last thing is the contraindication. So if you have a posterior wall deficiency, as we all know, a Salter will uncover it, and I'll have a video that shows that in a while. In a neurogenic hip, so a cerebral palsy patient, you wouldn't prefer to do a Salter osteotomy. And for Dega or Pemberton, the coxa magna. So if you have a large femoral head and you are decreasing the size of the acetabulum, then that's not a good option. Of course, there are combinations. So in the expert hand, so I can say, يعني, إذا تسمحوا لي أقول expert hand صار لي 11 years doing 300 something hips, we can do a bit of combinations. So some of the patients, we do a Dega shelf-like or a Pemper shelf. So these patients where we have the combination is not the norm. This is not your everyday bread and butter fish and chips. Now, if you're talking about older patients where the triradiate is closed, then you start to talk about Gans, shelf, or a Chiari osteotomy. And from what I've seen and from every paper that we've read, we know that Gans and triple are pretty much the same, and the difference between them is the degree of correction. Gans would go up to 60 degrees of correction, while triple will be limited to 50 degrees. And as I've shown that we still have time for remodeling, and the patient can correct that last 10 degrees of correction. So if you don't have a lot of revision cases, and a lot of older patients, then you don't need to learn Gans, which is very high technical, and it takes a lot of experience for you to have that osteotomy done. And the only contraindication in the salvage procedures are the open triradiate cartilage. So if a patient is younger, so the common scenario that we see in our clinic, I don't know about your clinic, is a 1.5 to 2 years old with a DDH with a acetabular index of 40 degrees. That's my average patients that I see 2 or 3 in every clinic. So my go-to procedure, that's why my go-to procedure is a Pemberton or a Dega osteotomy. And between these two, it's a surgeon's preference, and I'll explain in a while. Shelf and Chiari are presumably kept for salvage because they don't have a degree of correction. You're not correcting the deficiency. You're just covering and supporting the labrum so that the patient wouldn't have pain and the labral tear pain that they have. So it's not a good osteotomy that you do as primary. So Salter is still the gold standard, and it's our reference that we always refer to. So it's between the anterior superior iliac spine and the sciatic notch, and then you pull the distal fragment superior laterally. So would the video work? ولا أنا شغلة ولا أنتوا شغلونا؟ أنا شغلة؟ Okay. So that's a Salter osteotomy that you can see. And when you pull the distal fragment to superior lateral, you are uncovering the posterior part. So that's why, and it's hinging on the symphysis pubis. So if you put the patient in derotation, in internal rotation cast, or you do a derotation osteotomy, that hip will dislocate posteriorly. So it started not to be a very good option, especially if you're doing a femoral shortening. Dega and Pemberton is the common question that we have, which is which, right? People are usually confused between them, which is Dega and which is Pemberton. They have pretty much similar indications, prerequisites, as you said, 18 months old and above, open triradiate cartilage, and a congruent hip. So usually we do an open reduction with that to reduce the hip. The contraindications are the coxa magna and closed triradiate cartilage, so in older kids we don't use that. They have pretty much the same incision and exposure, and both of them are incomplete osteotomies, and they have high recall that does not require fixation. Now these are the differences. So a Dega osteotomy, both of them would hinge on the triradiate cartilage. this will, the Dega osteotomy will hinge on the medial side of the triradiate, and the Pemberton will hinge on the posterior limb of the ischial part. So this is the common difference between them. The type of cuts, the crescent shape, and the Pemberton, which is medial and lateral. Sorry. Yeah. So this is my video. I made this small model. This is a Pemberton osteotomy. So it is incomplete because the posterior column is intact, but you cover medial and lateral wall. You cut both of them. The graft, where you put the graft is where your deficiency is, so anterior or anterolateral. The Dega is a semicircular. Again, it takes half of the posterior column, but it does not touch the medial side. The graft is put wherever you have the deficiency. So you can put it anterior and lateral or posterior. Now, the San Diego osteotomy is where the posterior column is being cut. Again, it's like the Dega, the medial side is not covered. We usually put the graft anteriorly. So you can see the posterior column cut is the difference between the San Diego and a Dega osteotomy. And I guess that finishes the lecture. Another criteria that helps you select, if you're not sure if this patient is having Perthes disease, if this patient is, you're not sure about the coverage, patient post-AVN with a residual dysplasia, and it's very difficult to decide. And instead of doing MRI, that would require a general anesthesia, and it is static, I do arthrogram. Neutral and abduction position, how much of the superior pooling is there? Is there any hinged abduction or not? And you can see the difference in between the pooling. I'll go back. And you can see the superior pool is limited in the neutral position, and it is higher in the abduction position. So this is called hinged abduction. So this patient, even if you try to do a Dega or a Pemberton, they will have a cam impingement. Then you're not helping. You need some sort of a different osteotomy. The other thing in the arthrogram, which is dynamic and is very helpful, is you doing the push and pull view. So push and pull view simulate the patient's walking. And that would tell you if the patient is subluxing and if you need to do open reduction or capsulorrhaphy. So if on the push and pull view, especially on the push view, the patient is not subluxing and that labrum is not getting out, it means that you don't need to do an open reduction. You just need to cover that acetabulum. And the last view that I love, and you can see the labrum, how it moves. So this patient will need a support of the labrum because that will tear eventually and will cause the patient to have pain. And this is the Salter view during arthrogram that would show you how much covering will you get in a Salter osteotomy or a pelvic osteotomy. You can see the rose thorn that tells you that this is the edge of your labrum and this is how much the coverage you are getting. So this patient will benefit from a rotational osteotomy rather than a Dega or a Pemberton osteotomy. That's the take-home message. If you choose the correct osteotomy, do it right the first time, the patient wouldn't need surgery again. Thank you. Questions?
I do Salter osteotomy and I have good results with Salter osteotomy.
You have?
Good results.
Yes. If you have low acetabular index and the patient are remodeling, I think Salter osteotomy is still great, but in at least our cases, we need more correction.
Let's try.
It's not enough to have 10 degrees of correction.
Yeah. And is there any specific complications of doing Dega or Pemberton? And if you don't do the incomplete cut, what will happen?
So the beauty about the incomplete cuts is that you don't need to fix it. So there are no K wires, and you don't need to take the patient again after 6 weeks to remove the wires. And I changed the spica in the clinic. I don't take the patient for general anesthesia to change hip spica. What I do is putting bilateral, I complete the half side of the cast, I put the bar, then we remove the upper part. So the patient will not move, and at the same time I don't need to take the patient again to the OR.
the graft I take from the autograft from the iliacus.
So in the previous lecture, I've
don't
shown
have
you.
allograft as you.
Yeah, the autograft is still mentioned there. It is still the gold standard, but you need to have 3 pieces of that autograft. You need to cut a big chunk and put 3 pieces, because otherwise the recoil is very strong and you can have it extruded out. So it's better to have either allograft or
because they are strong.
the best is the femoral graft. So if you're doing femoral shortening, take that part and put it as a bone graft.
For Diga.
For the Diga and Pemberton, yes. That's my best to go graft. It's an autograft, and yet you're not disturbing the iliacus.
Sometimes you do need KYs to fix this allograft, or
No.
Never.
Never.
Not like salt.
Unlike Salter, yes.
Salter you need KYs.
You need it, yes. Otherwise, because it's complete, you cannot rotate and hold the rotation with only graft.
Any other question to Dr. Dalal? Okay. May I ask you all to come over to come closer, please, because the hall is very small and no need to stay behind.
عشان يشردون بعدين.
Closer relation. So can you come over here, please?
When you do the Diga osteotomy, certainly the hip is contained after you do the containment first.
Yes.
And then you perform the capsuloplasty, or you perform the osteotomy first and then you complete it. And the other thing, do you need at times to do femoral shortening and derotation osteotomy with it?
Yes.
Or not?
So the first question is, when do I put the stitches for the capsulorrhaphy? I don't do the T-shaped capsulorrhaphy, I do the elliptical shape. The T-shaped has a tendency to have limitation of internal rotation of the patients, and some of our patients still want to sit on the floor cross-legged, and that would be prevented by a T-shaped capsulorrhaphy. So an elliptical shape, I do open reduction first to remove everything, make sure that I have removed the false acetabulum, because there's where the osteotomy is. I put the stitches for the capsulorrhaphy, do the osteotomy, then close the capsulorrhaphy. Femoral shortening is intraoperative decision. It's usually reserved for patients who are older than 3, high dislocation more than 2 centimeters. But intraoperatively, if the patient is not reducing or very tight reduction, and there is no telescoping. So what we do is we put our finger when we make sure that we are reaching the triradiate cartilage on the medial side. From inside the joint. So if your finger with an X-ray is closer to triradiate cartilage, then we're safe and we don't do femoral shortening. I heard that in Tunis and also in Iraq, I've noticed that people are doing femoral shortening as a routine.
Well, it reduces, we notice that it reduces the incidence of vascular necrosis. If it is the head is a high riding.
Yeah, everybody's telling me it's reducing, but nobody's giving me numbers. And we feel that it is reducing, but nobody has a number.
I think shortening in case of easy upper reduction is contraindicated, because I've seen case Libyan child done in Italy. They did 3 centimeter shortening bilateral. She kept dislocating out, in and out, in and out.
True. 3 centimeters is too much
to treat. I think it is contraindicated sometimes.
Yes. Other questions? Next lecture.
Thank you.
Thank you very much.
Thank you very much.
Thank you so much, Dr. Dalal Bouchet. It was glad for me to know you during this Congress, really. Thank you so much for your nice presentation.
مع الأسف the second lecture is cancelled about the vascular necrosis and the time of surgery for unstable sleep with capital femoral epiphysis is cancelled. So we pass to the next lecture, which concerned one of the therapeutic method of the Perthes disease, which is not well known in Tunisia, I think. And this is the arthrodiastasis of the hip, which according to several authors can give an encouraging and good results in certain form of the disease. So we invite our dear Professor Yasser Batrawi to explain us this method. Welcome.
Thank you so much, Dr. Ghazlan. It was really my pleasure to be here with all these nice colleagues from all over the Arabian world, and I enjoyed very much the hospitality of our Tunisian colleague. And today I am going to speak about the management. No, this is, I'm sorry, this is another topic. Today is a Perthes disease. Okay, you know, or we all know that Perthes disease is very challenging problem. When you have a patient with Perthes disease, when you have a child with Perthes disease, you have to, sorry? No, what to do, how to manage Perthes disease? No. May I come on? Okay, I'm going to speak today about the new trends of management of Perthes disease. As you know, this is, okay, no. It doesn't work, this one. Okay. This is the vicious circle. You know, for when the Perthes disease starts, there is avascular necrosis of the femoral head. There is temporary cessation of growth of the epiphyses and softening of the cartilage over the head of the femur. And this is considered as a potential leg-calf Perthes disease. Then you have to wait till a revascularization happen from the periphery. And in later stage is reossification, resumption of reossification. This period take not less than 3 to 4 months. During this period, you have many possibilities. One of these possibilities is that the femoral head cartilage will collapse. And then you have all the complication of Perthes disease. And what happens if you do nothing? There is any trauma, any minor trauma, even if the patient, the child is walking, it leads to pathological fracture and resorption of underlying bone, and this leads to relapse. Relapsement by biologically plastic bones. So the head become like mushroom shape or magnified. It happens later on stage of subluxation and deformity of the femoral head. So how to reverse this or improve the situation? This is the virtuous circle. So you have to act before reaching to this stage. Okay. So, as you know, this is a Shenton line. Do you have another one? These. This is a gentle line, the normal gentle line, and we do arthrodiastasis to restore the gentle line. This is preoperative. This is not working. This one is not working. Do you have another one, please? Okay. Preoperative, there is a little collapse, a collapse of the head, disturbance of the gentle line. We do arthrodiastasis to restore the gentle line and create a negative pressure inside the joint. And this negative pressure insufflate the femoral head until the stage of revascularization and reossification happen later on. This is a device we apply. We apply a monolateral device and femoral arch. This is like semi-arch and monolateral fixator. And this arch, where there are 3 pins, one like delta shape in the acetabulum. And we use hydroxyapatite coated pin for better purchasing in the acetabulum cancellous bone. Well, and the femoral shaft, and then we distract the head. We need to keep this device about 3 to 4 months while the child is able to walk, because this is hinged distraction. It allows flexion and extension. We do adductor tenotomy. We put the lower limb in 30 to 40 degrees in abduction. So the device allows only flexion and extension of the hip, but not abduction and adduction. And we use this one. This is a special device. There is, it is cannulated. We apply wire as a guide wire to the center of the head of the femur, which is the center of rotation of the hip joint. So if you apply the device higher or lower than this level, the child will not be able to move the hip joint. So this is before the distraction, and after the operation, this is the follow-up, the final follow-up, with the gentle line is restored, the hip joint is preserved, not much, the head is not much collapsed. The battery is finished. Can you change this one, please? This is 1 year follow-up. The patient is able to do flexion, extension, abduction, and adduction, and all motion almost equal to the contralateral side. Next, please. Next, please. So, during the patient is able to walk, you should have very stable frame to have no being the problem, like being tract infection or loosening or so on, because you have to keep the fixator for 3 to 4 months. Thank you. And this is the same patient when he became 14 years old. This is about 5 years after the operation. And this is the we can do all the motion, abduction, adduction, internal and external rotation. Okay. This is the Shantel line before and the final follow-up. Nuno Lopes is my colleague from Portugal. He's the one who had great experience with this, and I learned from him actually a lot about this Bursi's disease. He stated a pre-leg calf bursitis situation known as ischemic disease of the growing head, the growing hip. He has developed a screening protocol as a guide of the probability of evolution of leg calf bursitis disease. He has developed classification, which is considering 3-stage using MRI study. The first stage, there is no actual ischemia with irregular contour, synovitis, and thick cartilage. Stage 2, subchondral ischemia, irregular contour, effusion, and synovitis. While stage 3, there is already porosis and subchondral ischemia, synovitis, and effusion. So, what are the forms of treatment for Bursi's disease? The classic form of treatment, like just wait and see, observation, traction, sling, spring, crutches, with or without cinder sling or Salter stirrup. Definitive early treatment to prevent a deformity, non-surgical or surgical, non-surgical as abduction cast or abduction orthosis. We know all of this and we use. Surgical treatment like femoral osteotomy, either varus osteotomy, derotational osteotomy, or combined varus and derotational osteotomy. The other form of treatment is doing innominate osteotomy combined with adductor tenotomy and the iliopsoas release. And late surgical treatment to correct the already happened existing deformity, like muscle release, arthrotomy, followed by abduction cast, partial excision of the femoral head, like peripheral chelectomy, central loose fragment of osteochondritis dissecans. Sometimes we do this arthroscopically. Abduction like valgus osteotomy, distal and lateral transfer of the greater trochanter, lateral shelf acetabuloplasty. And late surgical treatment for secondary degenerative arthritis like femoral osteotomy, arthrodesis, and arthroplasty. I already saw one e-poster about arthroplasty in Bursi's disease. So what are the main form of the treatment? In conservative treatment, as my colleague Dr. Esmat Ghanem yesterday mentioned about bisphosphonate therapy and prostacyclin, bone morphogenic protein, and new braces like probostate brace, or surgical treatment, as we mentioned here, by arthrodiastasis, hinged arthrodiastasis, transphysial neck drilling of the femoral head, that sometimes we need to do it bilaterally as prophylactic because many publications mention that the rate of affection of the other side is 30%. So sometimes we need to do prophylactic drilling. It is not, it's something that doesn't percutaneously and is not harmful. Core decompression, same as we do for avascular necrosis of the femoral head, the AVN, same management. New illuminate osteotomy, femoral head osteotomy, arthroscopic chondral cyst excision, or metal on metal resurfacing of the femoral hip joint. What is the value for arthrodiastasis? Is unloading of the hip was originally considered important in the treatment of Perthes disease. To truly remove all the compressive force from the hip, the muscular force must be neutralized. This can be accomplished by hip joint distraction with an external fixation. This is a different kind of the external fixation used. This is this device. Again, same problem. Okay, this device is invented by Orthofix. Is monolateral fixator. Is the same device I use, but with a small straight T-clamp. The problem for this is that the three pins are parallel together, while the pelvis in this area is convex. So what I did that I put arch, I added arch, like semicircular arch, to this T-clamp to convert it to be more anatomical, going with the convexity of the pelvis. So I have the pins exactly perpendicular to the pelvis and three pins like pyramid in shape. So a better purchasing and stability of the over the acetabulum. So this is my adding to the technique. Other specialists can use Elizarov, but this is non-hinged. You can add hinge here that allow motion. So it also you can use Elizarov component. However, I prefer the monolateral and the arch proximal. The aim of distraction is to neutralize the muscle and weight-bearing forces to prevent stress fracture of subchondral immature bone, to encourage synovial circulation and to promote creeping substitution by breaking the vicious circle of necrosis, creating a vacuum phenomena inside the acetabulum. So it insufflates the femoral collapsed head already, as we showed in the case I showed here, permitting to reconstruction of the spherical head. So this is a vicious circle as we showed about Perthes disease. So revascularization happened to, this is true, non-weight bearing, minimize the mechanical stress, prevent further episode of ischemia leading to healing. The advantage, it provides true non-weight bearing, thereby breaking the ischemic vicious circle of the femoral head and give a chance to heal in a relatively short time and even to remodel. It helps to achieve hip containment within the acetabulum. It provides new vascularization of the distracted tissue, enhanced blood flow around the distracted joint, change the ischemic nature of the Perthes disease. Next, please. Okay. This is another case. You can see the disturbance of the Shenton line here, and after the distraction, and this is after removal of the frame. You can compare the sphericity of the head and joint space to the other normal side. Next, please. This is the affected side with the preoperative and postoperative with restoring the Shenton line and improving the sphericity of the head after insufflation due to the negative pressure. You can see here the Shenton line return to the normal. This is the pre, this is the post. Next, please. This is the 3D CT scan. You can see the difference between the affected side and the normal side. Next. the transphyseal neck drilling of the femoral head, Lopez found that transphyseal neck drilling with the perforation of less than 15% of the gross plate, it means this is the gross plate. If you not exceed 15% of the diameter of the gross plate by transphyseal neck drilling, it doesn't affect the gross plate at all later on. So the gross plate didn't interfere with the growth of the proximal femur and induce a marked increase of epiphyseal microvascularization due to the formation of anastomosis between the metaphyseal and epiphyseal circulation. Combined early drilling and late distraction and the transphyseal neck head drilling leads to faster healing and shortens the time of arthrodiastasis frame. So what we do is adductor tenotomy, transphyseal neck head drilling, and then arthrodiastasis. Next. The cord decompression, it's the same we do like in AVN cases, with or without physiodesis of the greater trochanter, aiming also for restoration of the epiphyseal vascularity. Debridement require large core 8 to 10 millimeter reamer directed to the center of necrotic segment. We apply K-wire and take X-ray, EP, and lateral view to check, and then before the drilling with cannulated drill bit. Autograft and bone marrow injection or BMB injection, or doing new innominate stenotomy. Next, please. This doesn't work. These are the different kind of osteotomies that we use, and Dr. Dalal has great experience, as she mentioned in her nice presentation about this. Next, please. Femoral head osteotomy. This is, we do surgical dislocation of the femoral head with preservation of the blood supply. Next. And we do osteotomy of the femoral head, coxa magna. Due to coxa magna, we remove partially the bone, and then to restore the normal size of the femoral head. Next, please. This is the part we removed already, and then we restore the normal size of the femoral head comparing to the other side. Next, please. And then we fix with screws. You can compare the size now of the head comparing to the other side. Next. Sometimes I use another colleague who is expert in hip arthroscopy to do arthroscopic chondral cyst excision if there is stiffness of the hip joint, which is a complication of Percy's disease. A focal compressible chondral elevation was detected on hip arthroscopy. Another line of treatment, as we mentioned, is metal on metal resurfacing. And we also do a lot of resurfacing cases in our department by a colleague of mine. Thomas et al. Stated the advantage and disadvantage of resurfacing relative to conventional total hip arthroplasty. So, despite much research in the etiology, pathology, and method of treatment, the definitive the issue is simple. For us, when the person starts, there is a muscle necrosis of the femoral head. There is temporary cessation of growth of the head and softening of the cartilage over the femur. This is considered the potential leg cause surgery. You have to wait till the revascularization happens from the periphery. And later stage, resumption of reossification. this period takes not less than 3 to 4 months. During this period, you have many possibilities. One of these possibilities is that the femoral head cartilage will collapse. Then you have all the implications first. And what happens if you do nothing? There is any trauma, any minor trauma, even if the patient is actually walking, to pathological fracture and resorption of underlying bone, and this leads to relapse, relapsing by biologically plastic wounds. So the head becomes like mushroom shape of mankind. It happens later on the stage of subluxation and deformity of the femoral head. So, how to reverse this to improve the situation? This is the virtuous circle. So you have to act before reaching to this stage. Okay? So, as you know, this is the gentle line. You have another one. This is the gentle line, the normal gentle line, and we do after the stage to restore the gentle line. This is preoperative.
This is how we do. This is how this is.
This is not working. This one is not working. You have another one?
Just 1 minute.
Okay. Preoperative, the little collapse, the collapse of the head, the surface of the gentle line. We do arthrodiastasis to restore the gentle line and create a negative pressure inside the joint. And this negative pressure inflates the femoral head until the stage of revascularization and resuscitation happens. This is the device we apply. We apply monolateral device and femoral semi-arch and monolateral fixator, and these arcs are 3 pins, one like delta shape with the acetabulum. And we apply use hydroxyapatite protein for better shading in the acetabular, and the femoral shaft, and then we extract the head. We need to keep this device about 3 to 4 months. Why the child is able to walk? Because this is injured distraction, allow flexion and extension. We do adductor anatomy. We put the lower limb in 30 to 40 degrees in abduction. So the device allows flexion and extension of the rib, but not abduction and abduction. And we use this one. This is a special device. It is cannulated. We apply wire as a guide wire to the center of the head of the femur, which is the center of rotation of the hip joint. So if you apply the device higher or lower on this level, the child will not be able to move the hip joint. So this is before the final follow-up with the gentle line is restored, the hip joint is preserved, not much, the head is not much. 1 year follow-up, the patient is able to do flexion, extension, abduction, almost equal to the contralateral side. Next.
next.
Very stable frame to have no problem like infection or bleeding or you have to keep it stable for 3 to 4 months. And this is the same patient, very detailed, 14 years old. This is about 5 years after the operation, and this is the motion, abduction, internal and external fusion. This is the shelter line before and the final follow-up. The leader of this is my colleague from Portugal, who's the one who had deep experience with this. And I learned from him actually a lot about this person. He stated the 3 leg calcium situation known as ischemic disease of the growing head. He has developed screening protocols and guide of the probability of evolution of leg calcium. He has developed classification which considering 3 stage using MRI study. The first stage, there is no actual ischemia with regular contour, synovitis, and deep cartilage. Stage 2, subchondral ischemia, irregular contour, effusion, and synovitis. While stage 3, there is already neurosis and subchondral ischemia, synovitis, and effusion. So, what are the forms of treatment for Percy disease? The classic form of treatment, like wait and see, observation, traction, scratches with or without single fuse or shoulder definitive early treatment to prevent the report, non-surgical or surgical, non-surgical as abduction cast or abduction orthosis. Know all of this and use surgical treatment like femoral osteotomy, either varus osteotomy, relocation osteotomy, or combined varus and relocation osteotomy. The other form of treatment is doing phenomenal osteotomy combined with abductor osteotomy and iliopsoas release. And later with the treatment to correct that already happened in deformity, like laterally arthrotomy followed by abduction cast, partial excision of the femoral head, like peripheral colectomy, central loose fragment of osteochondritis vesicans, sometimes arthroscopically, abduction like valgus osteotomy, distal and lateral transfer of the fetus trochanter, lateral shelf acetabuloplasty. And late surgical treatment for secondary degenerative arthritis like femoral osteotomy, arthrodesis, and arthroplasty. I already saw one poster about arthroplasty in Percy disease. So, what are the new form of the treatment? In conservative treatment, as my colleague Dr. Esma yesterday mentioned about bisphosphonate therapy and prostacyclin, non-oncogenic protein, and new places like Bogus Place, or surgical treatment, as mentioned here by arthrodiastasis, arthrodiastasis, transfizial neck drilling of the femoral head, that sometimes we need to do it bilaterally as prophylactic because many publications mention that the rate of affection on the other side is 30%. So sometimes we need to do prophylactic drilling. It's not something percutaneously and it's not harmful. Core decompression, here as we do for a vascular necrosis of the femoral head, again, pain management, new elaborate osteotomy, femoral head osteotomy, arthroscopic condyle excision, or metal and metal resurfacing of the femoral head. What is the value for arthrodiastasis? Unloading of the hip was originally considered important in the treatment of vertigo. To truly remove all the compressive force from the hip, the muscular force must be neutralized. This can be accomplished by hip joint distraction, read, and external fixation. This is a different kind of the external fixation. This device. Okay. This device is invented by orthopedics. The same device as this, but in small The problem for this is that the three pins are parallel together. While the pelvis. So what I did is that I put arch, I added arch, like semicircular arch, this D-clamp to convert it to be more anatomical, going with the convexity of the pelvis. So I have shown exactly the pelvis and three pins like pyramid. So a better appreciating and stability of the extension.
الحديد ولا حاجة أخرى جملة مسنجة الحديد
other specialists can use without, but you can have here that allows for without. However, I prefer the modular and the arch. The aim of distraction is to neutralize the muscle and weight-bearing forces to prevent stress fracture of subcondylar immature bone, to encourage synovial circulation and to promote breathing substitution by breaking the vicious circle of necrosis, creating the vacuum phenomena beside the acetabular. So it supplements the femoral collapsed head already, as we showed in it's leading to reconstruction of the spherical head. So this is the vicious circle. So revascularization is to non-weight bearing, minimize the mechanical stress, prevent further ischemia leading to the advantage is provide two non-weight bearing, thereby breaking the ischemic vicious circles of the femoral head and lead the chance to heal in relatively short time and even to remodel. It helps to achieve heat containment within the acetabulum. It provides new vascularization of the distracted tissue, enhances blood flow around the distracted joint, to change the ischemic nature of the persons. Next, another case. You can see the disturbance of the gentle line here. And after the section, you can compare the electricity and joint space to the other normal side. Next, this is the affected side with the pre-operative and post-operative, which is restoring the gentle line and improving the stability of the head after insufflation due to the negative pressure. You can see here the gentle line returns to the normal. This is the E, this is the O. Next, please. This is the 3D CT scan. You can see the difference between the affected side and the normal side. Next. The transfibrial neck drilling of the femoral head. Lupus found that transfibrial neck drilling with a perforation of less than 15% of the gross plate, it means this is the gross plate. If you not exceed 15% of the diameter of the gross plate by transfibrial neck drilling, it doesn't affect the gross plate later on. So the gross plate didn't interfere with the growth of the proximal femur and induce a marked increase of epiphyseal microvascularization due to the formation of anastomosis between the metaphyseal and epiphyseal circulation. Combined early drilling and late distraction and the transfibrial neck head drilling leads to faster healing and shortens the time of arthroderostasis frame. So what we do is abductor tenotomy, transfibrial neck head drilling, and then arthroderostasis. Next. The core decompression, typically we use in AVN cases with or without fibrosis of the greater trochanter, aiming also for restoration of the epiphyseal vascularity. The treatment require large core 8 to 10 millimeter reamer directed to the center of necrotic segment. You apply K-wire and you take X-ray, ED, and lateral view to check, and then before the drilling, you can cannulated autograft and bone marrow injection or ELD injection. What do we do now in stenotomy? Doesn't work. These are the different kinds of stenotomy that we use, and Dr. Talal has nice presentation. Femoral head osteotomy. This is surgical dislocation of the femoral head with liquidation of the blood supply. Next. And we do osteotomy of the femoral head. Foxa magna. We do foxa magna. We remove partially to restore the normal size of the femoral head. Next, this is the part we removed already, and then we restore the normal size of the femoral head compared to the other side. Next, and then we fix with the screws. So you can compare the size now of the head compared to the other side. Next, sometimes we do another colleague who is expert in deep arthroscopy to do arthroscopic contrastive excision if there is a stiffness of the hip joint, which is a complication of Percy disease. Focal compressible chondral elevation was detected on deep arthroscopy. Another line of treatment, as you mentioned, metal and metal researching. And we also do a lot of research in our department by a colleague of mine. Thomas Hell stated the advantage and disadvantage of researching relative to conventional total deep arthroplasty. So, despite much research in the etiology, pathology, and methods of treatment, the definitive cause of Perthes disease remain not well understood, and the treatment therefore remain empirical. A new method of treatment such as arthrodiastasis achieve true non-weight bearing, breaking the vicious circle of necrosis, not limited by hip stiffness, degrees of femoral head deformity, or subluxation. Thank you so much. Any question? Come here. I cannot hear. I have a hearing problem. So.
Thank you for your presentation دكتور ياسر. سؤال لثلاثة على الفريم. أول حاجة هل نقدر نستعملوه إنه في bilateral Perthes in the same time؟ أولاً.
I never see bilateral Perthes at the same time. Okay. I never see in my life.
Okay. And the degree of deflection and extension given.
Sorry?
The extension and deflection degree with the frame, with the hinge, about degree and the comfortable the patient with the setting or not.
I'm sorry, I didn't understand your point.
يعني الديجري بتاع الفليكشن والاكستنشن في الهنج قديش تعطي؟ How much?
No.
And the patient is comfortable or not?
Yes.
In the setting.
The frame allow full flexion. And full extension.
And the setting is comfortable.
Not limited. No limitation. The limitation only in abduction and abduction. Zero.
Time of weight bearing? Time of weight bearing by the frame?
Partial weight bearing.
Immediately.
40-50% weight bearing, not too much, because you have here just 2-3 pins distal in the femur, and the longevity of the frame, it's about 3 to 4 months. So you have to be careful.
And use the distal with the flexion knee or the extension knee?
I'm sorry?
When they insert the 3 pins distal. When the flexion
during the operation.
Yes.
Okay. During the operation, your pins should be in the corridor, not to do impingement with the muscles around the femur. So يعني بنحس الجزء اللي هو الخارجي تحت الفاشيالاتا وبعدين insert wire percutaneously, and then you have to check this wire anteroposterior and lateral. The lateral, the wire should be exactly in the center of the femur, okay? Not in the periphery. And then you insert the pins. After that, you have to bend the knee. If it's okay, no problem, no tethering, then it's fine. If there is any tethering, you have to بتستخدم scissor under the pin to release, to do releasing of the pin, and then you have to be sure that the knee joint is working very well. Otherwise, the patient will get a stiffness of the knee joint.
Thank you, doctor.
You're welcome.
Thanks. If you do a dissection, a progressive dissection, and how much?
If I do what?
Progressive dissection. And how much?
Yeah, I didn't mention that. We do this distraction 50% during the operation and 50% gradually later on. So it depends on the Schentel line. If the Schentel line is, you saw some cases about 15 millimeter less than the normal. So we do 5-6 millimeter acutely intraoperative, and then the remaining 10 millimeter, for example, over 10 days, 1 millimeter per day, until you reach restoring the Schentel line. Then you lock the frame, and you leave the patient walking and moving 3-4 months until the revascularization happen to the femoral head to prevent the collapse.
I think to confirm, the effect of this technique in this disease.
You speak French.
No.
Sorry.
عربي peut-être.
Arabic. Okay, fine. Arabic.
Pas du tout arabe.
Speak Arabic or English and then I
speak
explain to
English.
you.
I speak English sans problem. To compare this technique, to confirm this technique is.
To confirm?
This method, we have to compare the same pathology and example with the CIS techniques and now observative. So we have a patient, je l'ai hospitalisé, donc j'ai admis, with to do these techniques. Finally, we don't not. We have an excellent result with no techniques, knee surgery, knee bracing, knee arthrodesis. So, see, but 7 years.
I agree with you because until now it is not very popular to do this because you should have scientific evidence. Understand me? I agree with you, absolutely. But the results.
Thank you. I have a question and a comment.
Because before you say, because this is the same debate happened every day in pediatric orthopedic meeting in United States between the specialist doing arthrodiastasis and the specialist who are not believing in arthrodiastasis. You know, this is a medicine, and we have in hand of Nuno Lopez, in my hand, in hand of Dror Pelli, John Herzenberg, many specialists, they do arthrodiastasis, and they consider that the transphyseal neck head drilling is an emergency operation. When I see diagnosed patient with Percy disease, and the MRI study done, and the head is spherical, everything is okay, and he just has pain, then it is considered as emergency. I take the patient to the operating room, I do transphyseal neck head drilling as a first step. Then we monitor. If things propagate, I do arthrodiastasis. Or if from beginning I found the head is little collapsed, then I do transphyseal neck head drilling and arthrodiastasis in the same setting. So other people, they go in the same classic way as we used to do many years.
So my question is, when do you remove it? So is it a strict 4 months, or do you wait for remodeling first?
Actually, 3 to 4 months are enough.
So it's time or X-ray?
No, time.
Time only.
No evidence about time. Why remove that? Because all the studies mentioned that the revascularization happened within 3 to 4 months.
Up to 6 months. My comment about Perthes disease is, as you said, it's the most controversial disease. Mm-hmm. If you give, Herring did a study about the classification itself, and he gave it to his team, 100 cases, 4 surgeons, and they gave different classes. And this is in the center of Philadelphia where Herring works. Mm-hmm. So that's the most controversial disease. The problem with Perthes is that it's algorithm and case-based. You cannot say that all cases need diastasis, all cases will have surgical dislocation, and all cases will have observation. To standardize the patient is very difficult. You need their age, you need the stage, you need their, and we don't have enough number. It's not very common in the Middle East, like in India, for example. On the other side, we have more SCFI and more DDH than they do. So for DDH, the transphyseal drilling, what I saw with Dr. Dropeli is that he has a special drill that is smooth, and then when you put it on reverse, it opens. So it's a very special drill that protects the growth plate. It's not the usual drill. So it's not for everybody to start doing transphyseal drilling because it doesn't make sense. We did it in sicklers and it didn't work that much. And if you do transphyseal drilling, then you're scared of collapsing the head. And I think, I didn't read studies about the prophylactic drilling, but I understand SCFI because SCFI is 30 to 50%. I would do prophylactic fixation. But for 15%,
Not prophylactic fixation, prophylactic
yes.
transphysial neck head drilling.
For SCAFI, prophylactic fixation because it's up to 50%. But for 15%, I wouldn't touch a normal
Not for
side.
15%.
15% is bilateral. Huh?
The bilaterality reached to 30%. So
Who
personally,
would drill the
I don't do contralateral transphysial neck head drilling. I said that it is possible to do.
Okay.
I didn't say that I did that.
Yes, because it makes no sense to drill a
Yeah,
normal
but I
side.
say that some specialists now are doing prophylactic drilling. For me, for many medical legal reason, I don't, because the patient in Middle East think that you are going to operate the healthy side, you are doing over, especially in the private practice. In public, if I do prophylactic, no one will blame me. You know, it's something we do. I'm doing something scientific, but okay.
Excuse me.
You are absolutely right. Yeah. Thank you.
I noticed that you do arthrodiastasis for early stage and late
I'm
stage.
sorry, repeat again.
I noticed from your presentation that you've done arthrodiastasis even for early stage when there is only sclerosis of the epiphysis. So do you do it for all cases of Pertus disease, arthrodiastasis, or only?
No, no. I said in early stage when the head is not deformed, transphysial neck head drilling is considered like an emergency operation.
No, but I noticed
Yeah,
that
I
you-
thought.
arthrodiastasis.
For arthrodiastasis, if the head started to collapse, we do arthrodiastasis. If not, we don't do arthrodiastasis because many cases can, you all follow some cases that go in the right way without stiffness, without problem, and the sphericity of the femoral head is okay. So,
Is there any, in the literature, is there any long-term study for this technique?
I didn't publish study about this technique. I didn't publish,
is-
but there are some already publication mentioned about that.
They do that only in fragmentation phase. So during fragmentation phase, it's not advisable to do varus or a shunt osteotomy because the femoral head is too soft.
Yeah.
So that's the only procedure you can do in fragmentation phase. It's
In
just to
between.
prepare it, just to give that femoral head time to revascularize.
Early stage
So it's
fragmentation.
early stage.
Early stage, yes. Yeah. Okay. Thank you.
Okay. Thank you so much. Thank you.